My name is Sarah Tahamont. I'm at the University of Maryland. I'm chairing the panel today. We have 4 great presentations to look forward to. First up will be Ashton Verdery from Penn State University, talking to us about social networks and opioid misuse.
Thank you for having me. I'm excited to be here. This is a collaborative project with a number of co-authors, including Glenn Sterner, who's a criminologist at Penn State, Shannon Monat, who's a demographer at Syracuse, Catherine McLean, who's a criminologist at Penn State, and an ethnographer, Kari Rigg at University of South Florida, and Alex Chapman, who's a student in sociology at Penn State. This project originated a few years ago where we were interested in collecting data on the social networks of people who are using opioids in Western Pennsylvania. And it's been an ongoing project that's involved over 2 years of data collection, and we're still kind of in the data analysis phase. So a lot of this is really preliminary, but I think some of it is interesting. I think it's helpful to kind of think about what opioids are. Sometimes not everyone is as familiar. In this project, we're considering both prescription opioids, including things like oxycodone, hydrocodone, heroin, and synthetic opioids like fentanyl and carfentanil and other things like that. In general, opioid misuse is a huge problem in the United States today. There's estimated approximately 12 million Americans using heroin or prescription opioids. This has led to a large spike in overdose fatalities. Currently, the rates are higher than suicides, car accidents, homicide, and flu, but it's a little bit less than diabetes. So in the scale of reasons that Americans are dying, this is a huge source, larger than peak HIV epidemic deaths in the United States a couple decades ago. The current estimates suggest that there's about $504 billion of annual costs associated with the epidemic in the United States, stemming from lost productivity, healthcare costs, and criminal justice enforcement and policing. There's also huge effects of this on people's lives, both on individuals, families, and communities. I think it's a common experience among people in the United States to know a family member or a close relative, or maybe someone that one went to high school with or something like that, that has suffered from addiction to opioids and possibly overdosed. Most of the deaths in opioids occur in the prime working ages, making it a large concern for U.S. mortality trends. People have linked the opioid overdose crisis to declining life expectancy in the United States in the last couple of years, which is an unprecedented occurrence in developed economies, and only a few countries have begun to experience actually declining life expectancy rates. As a person who primarily studies things related to aging and kind of end-of-life care, it's particularly interesting to me to think of opioid misuse because many of these people are really densely tied within family networks and have parents of their own, children of their own, siblings, spouses, and friends. And their kind of relations extend to all ages and all life course periods. And when I usually study things, I usually study things that are kind of end-of-life things. So this is a different phenomenon for me to think of people who have small children that their misuse and death affects the lives of those children. So it's a particularly kind of thorny social issue. People in the United States typically describe the opioid overdose crisis as having sort of 3 waves. The first wave, people link to the prescription opioid kind of crisis that occurred in the early 2000s, where people began misusing prescription opioids like oxycodone and things like that. You can see in the death rates that in the early period there was a large rise in deaths from prescription opioids. Later, there was a huge rise in deaths from heroin. People attribute this to the federal government cracking down on kind of doctors that were prescribing and some of the distribution channels that occurred through prescription opioids, as well as changes in the abuse deterrent kind of pills that were invented around 2010 in an effort to kind of make it more difficult to abuse pills. During those events, generally people believe that individuals transition to heroin misuse, and you can see this large spike in heroin misuse represented by the green line around 2010. More recently, in the last several years, there's been a stark rise in fentanyl deaths and other synthetic opioid deaths, and this rise is really what's driving the massive overdose statistics today. You can see this here, this clear rise in the last 2 or 3 years of individuals who have overdosed on synthetic opioids. Our study is based in Pennsylvania, which is one of the harder hit states in the opioid crisis. In general, the Northeast and Midwest have been most hard hit. Pennsylvania has recently outpaced the national average for overdose deaths with substantial growth over the recent period. Currently, it's the 8th highest state by overdose counts, representing a 700% increase in overdoses since 1999. For a while, Pennsylvania was lagging the nation in overdose rates, but it's more recently has surpassed the national averages. Within Pennsylvania, there's huge stratification from region to region in the rates of overdose mortality. In general, overdose mortality, population adjusted, is the highest in the southwestern corner of the state in the greater Pittsburgh region, including several of the rural counties surrounding there, like Fayette County and Greene County. Overdose mortality is also quite high along the kind of highway corridor around the state capitol, near Harrisburg, and then also high in the Philadelphia area. So some of the largest cities in the state have high overdose mortality, but also several of the rural regions surrounding those large metropolitan areas. Overdose mortality is generally quite low in the primarily rural kind of middle of the state where I live and where Penn State is located. In the US, we've generally come up with a prevailing narrative about the opioid crisis. This narrative is that individuals are prescribed opioids through kind of legitimate means. They break an ankle or they have a dental surgery or something like that. They become addicted to opioids, and then during that crackdown period where the federal government began policing distribution channels more strongly and where pills became more abuse deterrent, people began to transition to heroin because of cost and availability concerns at that period. The narrative generally stresses this kind of diversion from legitimate means, but less is really known about the actual access points or the transition points, and our study was sought to shed light on some of that. I'm not going to talk about it as extensively today. Our research questions in this is what factors are associated with transitions into opioid use and escalation, and how do individual opioid misuse affect people's personal networks? This is the question I'm going to deal with primarily today because we have recently published a few papers about the first question. The study is based on 4 rural counties in western Pennsylvania, located in that kind of epicenter of the challenge in the southwest. This includes Allegheny County, which is a primarily urban county, though it does have rural areas, as well as 3 rural counties surrounding it, Washington, Greene, and Fayette. We looked at people who self-reported active opioid use within the past year, limited the sample to people who are 18 and older. Unfortunately, we had to use a non-probability sampling design that was a combination of kind of target-based sampling strategy and a referral-based sampling strategy from kind of responder-driven sampling methodology. This limits our ability to make generalizations beyond the particular sample case, but this is not an uncommon circumstance in in-depth research on social networks, and we are attempting to understand some of the processes in individuals' patterns of opioid misuse through both social network analysis and qualitative data analysis. So I think that the limited generalizability is, although a limitation, not uncommon for what we're trying to do as a first step. In general, these counties are quite diverse, and they span the range from very urban places to quite rural places. They also have a pretty stark differentiation in poverty rates. For instance, almost 20% in poverty in Allegheny, in Fayette County versus about 13% in poverty in Allegheny County. They are primarily white counties, reflecting the composition of western Pennsylvania, and they have pretty staggering differences in overdose mortality rates for including some counties that have quite low and some that have much higher. But in general, it's within the state of Pennsylvania, they're all on the high end. Our survey consisted of multiple parts, and I think this is one of the real challenges of doing this research. We did an initial survey at a first time point in 2017. During that time period, we asked individuals about their social networks and other demographic characteristics, about their use patterns and things like that. We also asked for a retrospective module on their initiation point of opioid misuse and about their social networks at that initiation point. A few weeks later, with a subset of these individuals, we did a qualitative in-depth interview that lasted from 1 to 2 hours, targeting information about how they access their networks and how their social relationships were affected by and affected their use. And then we waited a year, which was a very excruciating period. In doing so, we then followed up with about a third of the respondents and then did a follow-up in-depth qualitative interview with a small subsample. We did this survey about their demographics as well as about their social networks, and our interest was in understanding, for this study, how their networks might have changed over this time period. We asked about their networks from a diverse set of perspectives. First, we asked about their romantic partners. We also asked about who they considered their best friend, who they considered people that they go to for advice, using kind of standard questions about social support, and then who they engaged in social activities with. In general, the sample reflects the counties that it's from. It's overwhelmingly white. It's on average about age 35. It's slightly more male than female, and primarily from the largest county that we've sampled. We have a number of findings relating to individuals' beginning of opioid misuse. Almost everyone in the sample had either misused heroin or prescription opioids. Most had used both. The reasons that people transitioned, we have a number of studies about this. We have some interesting findings regarding gender, but what I wanted to focus on today was about their social networks. I think that one thing that's an advantage of looking at kind of smaller qualitative studies is you can actually kind of just show the raw data, and it really kind of illustrates some of the key points. So I'm going to show a few of these social network graphs that we had individuals draw of their networks and who's associated with whom. In here, the circles represent someone that they nominated in each position. The lines represent ties between people in different positions. On the far left is the retrospective when they first started using. In the middle is when they began, or when we interviewed them for the first time. And then on the right is the prospective follow-up study. Many of the social networks that we looked at looked like this, with dense kind of social networks at initiation, slightly less dense and more compartmentalized networks at the current initial time survey, and then real collapses in the networks over time. This is one user. This is another person who was using. This is another person who was using. And in general, this pattern was held for almost all of the respondents. Obviously, there are cases where it's not true and the opposite occurred, for instance, this case. To quantitatively summarize these things, we can look at the mean number of people that individuals were nominating at each time period. At first drug use, on average, people were nominating about 4.5 people, whereas at the follow-up interview, people were nominating about 3.5 people. This is, if you think of general surveys of social networks in the United States, where people have made raised large concerns about declining social networks in America, this number of losses of ties is comparable to what people point to as a crisis in social capital in the United States, where people went from an average of 3.5 social network connections to 2.5 social network connections between the 80s and the 2000s. We saw notable differences in their networks by gender. Women tended to have smaller networks with more stability. Men tended to lose ties more quickly, and they tended to lose ties especially to people who never used and current users. One of the more interesting things that we're exploring today is, exploring in the current work, is what percentage of people, how their networks were affected when they were in treatment versus out of treatment. We saw very few differences in the network change between people who participated in treatment versus not, but we saw substantial differences in network change between people who participated in peer group treatment versus not, where people who participated in a peer group kind of based treatment tended to have larger networks to begin with and see slightly less decline than people who didn't participate in a peer group treatment. In general, we saw most of the ties that were lost were among these kind of people that we asked about who were considered social activities ties, people who people spend time with, doing things like hanging out, going to the movies, playing video games, and things like that. And our preliminary analysis of the surveys indicate that a lot of that tie loss is from people who overdosed rather than kind of loss of the connection. The person no longer exists. We have a number of emerging themes from the interviews surrounding losing ties. the lack of ability to replace ties, and how social networks are impacting individuals' use. We also saw substantial roles for family ties in kind of initiation and escalation of use. Many people began initiating from peers in their family or siblings of their friends. And we saw a real desire for connection among many of the respondents, reporting that the lack of social ties was majorly impacting their lives and leading them to have real trouble beginning treatment or staying in treatment because they felt little motivation to do so. We have a number of future directions for this project, including continuing to disentangle the mechanisms by which individuals' networks become primarily dominated by others who use or previously used. We have a number of projects related to interactions with the criminal justice system and gender, as well as how children play into people's decision-making around opioid misuse. Thank you very much, and I wanted to thank our funders for the project, including the Criminal Justice Research Center and the Social Science Research Center at Penn State. Thank you.
Thank you very much for coming this morning. My name is Greg Midgette. I'm presenting some research that I've been working on with Peter Reuter, and so it's really exciting to be able to present it here at a conference in large part in his honor. And we're looking at a really important and heavily studied area in drug policy in the United States right now, marijuana legalization or cannabis legalization, and particularly what are the consequences of legalization among adults, among adolescents and youth. So quick roadmap of where I'm going to go with this talk. First, I'm going to give a really brief primer on the data that we look at typically in the United States with respect to adolescent drug use and particularly cannabis policy. I'll then briefly describe the most common drug use surveys that capture adolescent use. Then I'll describe cannabis legalization in the United States with respect to two papers that use a particular survey, one looking at decriminalization, so a change in the legal status of marijuana in California about a decade ago, and then a study more recently of recreational marijuana legalization in Washington state. So the bottom line with respect to data on drug use is that most of the data are flawed, and all of the data are flawed in a variety of different ways. When we look at administrative data, like the number of treatment admissions that occur in some location, and that's a nationally available data set in the United States, a data set called TEDS aggregates any treatment admission that occurs among a publicly funded institution in the United States. Treatment admissions don't cover all drug use, particularly for marijuana or cannabis, but they're a good proxy for dependence. Conditional on network capacity, meaning if there aren't enough treatment beds for someone, they're not going to be admitted. So as long as you're not under the capacity constraint, you're going to have a pretty good measure of some part of drug use. At the same time, there might be competing priorities, particularly for referrals to treatment from the criminal justice system. Priorities might be for individuals that are in the criminal justice system and have some opioid use dependence issue. They might take priority in the judge's or parole officer's eyes over a cannabis user. And then we have survey information, which is also flawed for a few different reasons that are distinct from administrative data. One is that it's expensive to collect survey data, as Ashton described, and it's hard to get at drug users. Cannabis is less difficult than opioids or heroin. So the data are collected infrequently and from fewer respondents than we'd want, essentially because it's very expensive to do. But even when we collect the data, we have reason to believe it might be dubious because people don't have a whole lot of incentive to be honest. So they might respond strategically or might not remember faithfully if we ask, how many days in the past month did you consume cannabis? I might remember that with precision, I might not. If you ask me how many days I ate a peanut butter and jelly sandwich, I have a general ballpark idea. It wasn't every day because we ran out of peanut butter. It's somewhere in the neighborhood of 20. So that's an important fact for you all. So there's also reason that people wouldn't necessarily always underreport their drug use. They might be overreporting their drug use strategically as well. We fielded a survey immediately before legalization occurred, recreational legalization occurred in Washington State, and we're looking for strategic responses. And Rob McCoon's in the back of the room. I think I see him. And so we worked really carefully to see whether we could figure out strategic responses. But I also just went on an internet forum where cannabis growers were discussing the survey and talking about, well, what they really want to see is that they're going to make a lot of tax revenue, so let's tell them we consume a lot of cannabis. So people have incentive maybe to overstate when it suits their needs. So overall, we might expect some bias in some direction, but the power of that bias is ambiguous. So for that reason, because these data are imperfect, our understanding of drug use and drug consumption and the relationship between drug use and crime is really more a synthesis of these single data sources that we know are imperfect. Part of that is understanding their flaws, though, and exploiting positive things about other data sources that might fill in where gaps exist in one. So in that respect, we're not looking, it's not as if we're doing studying the physical sciences, where if you're approximately at sea level and humidity is about the same in one place, say in Sweden or in Santa Monica in California, generally speaking, we might see nature sort of work in the same way. Here, for drug use, the drugs are changing. The norms surrounding drug use and talking about drug use are changing from location to location and over time. So we need to patch together, stitch together all of this information the best way possible. And that's what I'm going to be presenting on for the next few slides. Basically, the independent data sets collected independently that are supposed to be describing the same phenomena, do they corroborate one another? And if not, why? So really quickly, cannabis policy in the US is occurring at the state level, because at the federal level, it's still illegal to possess and consume THC-rich cannabis. THC is the main intoxicant in cannabis. The wave of recreational cannabis legalization started in 2012 by ballot initiative in both Colorado and Washington State. And today, there's 10 states plus the District of Columbia, the nation's capital, that allow adult recreational cannabis use. And all but DC follow a commercial model, meaning that they're for-profit companies that are selling cannabis products that are regulated by states and municipalities or localities. And then those states and localities get to tax sales and use the taxes as they see fit. So everywhere but DC in the United States that has a legal program, that's how it works, generally speaking. So we're worried about cannabis consumption among adolescents still, because there's compelling evidence that it could be problematic. So this is a summary of a meta-analysis by the National Academies of Sciences, that there's substantial evidence, particularly that initiating at early age, initiating cannabis use is a risk factor for development of problem cannabis use later on, so dependence or abuse. That cannabis use is associated with development of schizophrenia or other psychoses with the highest risk among the most frequent users. And so those are imperfect studies, but there's enough of them pointing in the same direction to make us concerned. And then there's moderate evidence of associations of cannabis use with impairment in cognitive domains, and so learning and education, memory, which matters a lot as your brain is still forming as an adolescent, and also suicide ideation, suicide attempts, and completion, and the higher incidence, and there seems to be a dose response there too. So heavier cannabis use is associated with higher risk of suicide ideation. So we have 3 different data sets that we can look at regarding adolescent use. The first is the National Survey of Drug Use and Health. That's a nationally representative annual survey. It's our gold standard for a general population survey. It's based in the household, as I said. Each year's responses are nationally representative. Combining 2 years of responses allows for state representative samples. About a quarter of the 55-ish thousand responses or respondents per year are between 12 and 17 years old. Then there's the Youth Risk Behavior Survey, which is every other year conducted at the state level, and additionally in large school districts, somewhere between 20 and 25 per year. The Nationally Representative Survey has about 15,000 students across between 120 to 150 schools in the United States. And then there's also state-level surveys that are similar in structure to this YRBS, but might go in more depth. For example, I'll discuss the California Healthy Kids Survey and the Washington Healthy Youth Survey. The latter is an almost census-level survey of public schools in the state of Washington. And finally, there's Monitoring the Future, which is another very powerful nationally representative survey that's done annually, collects information from about 50,000 students in 420-ish schools. It's nationally representative. It's not state representative, but because it's powerful in a fairly large sample size, it's been used for state-level analyses. I'm going to point out how that might be problematic. So the papers I referred to earlier by Mish and Serta and their colleagues looked at legalization in California, decriminalization, so the removal of a criminal penalty associated with marijuana possession in California in 2000, it was implemented in 2011. They found that there was no effect among 8th and 10th graders, but among 12th graders, so people at the end of their high school experience, there was a large increase in cannabis use, 25%. So they tried to explain that as a cohort effect. So reduction in penalties associated with marijuana doesn't really affect, for adults, doesn't affect 8th and 10th graders, but does affect 12th graders. Then Serta and her colleagues looked at legalization in Colorado and Washington, again using Monitoring the Future. They found an increase in use, so a reduction in, increase in availability, practically, for adolescents, though not directly. Find an increase in use among 8th and 10th graders, but nothing among 12th graders. So even though the sort of stimulus is generally similar, the direction of change is different. And that was interesting to read, and that I think motivated Peter's interest in this topic, in the use of Monitoring the Future in this way. Is it a cohort effect, or is it a sample size or a power issue? And we have an ability to look at the composition of the data, but only in a general sense, because Monitoring the Future data with identification information for the state of respondents is not publicly available. There's a small set of researchers that look at the data at that level. But we could tell from the information given in the papers that about 13 high schools per grade per year in California are sampled in Monitoring the Future. That's of about 1,300. And in Washington, approximately 16 schools per grade per year. And that's of about 1,000. So schools stay in the sample for a maximum of 2 years, and this is Monitoring the Future, and up to 350 students per school are sampled. So if a school is bigger than that, they don't ask anybody past the 350th. So when we look at the different available data sets in California, the solid lines, the green, red, and blue lines, are the Monitoring the Future estimates of use, and you see that they're more volatile. We also see distinct rise in grade 12, but we don't see that for grade 8 and 10. The other data sets are generally smoother and don't show a whole lot of distinct movement. There's an increase, but it's not statistically significant. So we can look at the Washington Healthy Youth Survey. So we can look at the variation in Los Angeles County. So if schools are leaving the sample every 2 years, they have to be replaced. And they say generally they try and replace the schools with something similar. But similarity is really difficult, especially when it's not really clear how you would define similar. So say Los Angeles, where I lived for the previous 15 years. Dense, it's all Los Angeles, all part of the same school district. We see a fair amount of variability within those school districts in terms of past month prevalence. So say that you take a school from District 1 and replace it with a school from District 2 in the pre and post period, you would go from a 9% prevalence rate to a 7.5% prevalence rate. That's a large decrease, artificially large perhaps. And it's just because there's not a whole lot of schools that are being sampled. That's some evidence that there's a question, but we'd want something more powerful. And so to do the more powerful analysis, we look at Washington's Healthy Youth Survey, which again, I said, is drawn from roughly 1,200 schools, so all of the public schools in the state. They do a random sample of about 110 schools, but allow any school to respond to the survey. And most of the schools do. And so it's conducted every other year, so not every year like Monitoring the Future, but it gives a whole lot of information, and not every school participates, but we can assume that any school that would participate in Monitoring the Future would probably also participate in the Healthy Youth Survey, or that there's no public school that would be in Monitoring the Future that wouldn't also be in the Healthy Youth Survey. So they're redundant, but the Healthy Youth Survey is way bigger. So what can we do? We can simulate. If we took the Washington Healthy Youth Survey methodology for sampling to make their state representative sample, and we took the Healthy Youth Survey, so 16 schools versus 110, up to 350, versus no cap, and with replacement versus with replacement every 2 years versus every year, what happens? Well, the green distribution, the green histogram in each of these charts for grades 8, 10, and 12 are the sampling under Monitoring the Future. And the vertical green lines in the top two graphs are the statistically significant estimates that were found in the CERTA paper. So those are in the tail, but they're not outliers. But they represent a couple different things, that just by random chance from sampling variation, we can have a big distribution. The other estimates, the Healthy Youth Survey sampling is a tighter distribution as we'd expect because it's a bigger sample of more schools with more students. We find, strangely, so this leads to a couple different things. Survey design definitely matters. We need to recognize that what a sample represents before we do the analysis, and don't wait for somebody to figure out that it might be wrong. And that in some ways, Monitoring the Future and the Healthy Youth Survey, for example, are complementary. Monitoring the Future asks private schools, so students outside of the public school sampling frame, whereas the Healthy Youth Survey doesn't. Maybe there's some efficiency gains because they're asking the same questions, using similar infrastructure. Maybe they're complementary in some way. Just because, so the size of these differences, I'm going to go back quick, between the CERTA estimates using Monitoring the Future versus the estimates using the Healthy Youth Survey are big enough that we couldn't say with any real confidence that the addition of private schools leads to this big difference. But we can potentially save some money, come up with better estimates by figuring out ways to synthesize those data, to synthesize the sampling frames. So there are a few remaining questions. One, why did youth cannabis use prevalence fall when legalization occurred? That's what we saw. Like a distinct fall in grades 8 and 10. No real effect in grade 12. Maybe it was enforcement, or maybe norms, or maybe it's just not cool to consume cannabis when it's legal, or because your parents are doing it, it's less cool, it's suggested. How can we account for changes in norms when looking at self-report data? Because norms are going to change rapidly with legalization. And that's exercise. That's all I have. Thank you.
Okay, I'm Tom Loughran. I teach at Penn State University. I want to take a minute to acknowledge my colleagues on this project. This is we're interested in adolescent problem behavior, particularly adolescent substance use and early onset substance use, which Greg very elegantly explained, is a problem for lots of different reasons. So I want to take some time before I start to start with some motivation for this project. So this is actually not my study, this graph that I'm presenting right here. This is some work that was done by Jonathan Elmer, who's an ER physician. And this is data on something called your suppression ratio. So this is a sample of cardiac arrest patients who were admitted to a hospital, and time on here is 0, okay? And they took a measure, this physiological measure of basically your brain functioning. I'm not an actual doctor, I'm not exactly sure what it means, but the closer it is to 0, the higher your executive functioning is. So what these graphs represent is time from they were admitted to the hospital. And you can think of these patterns as kind of latent strata or averages of patterns in the data. And what they found was that, first of all, that these patterns were highly predictive of survival, whether or not you actually left the hospital alive. And also what they found was very quickly, like within 12 hours after they were admitted to the hospital, they could classify which of these patterns you were following. All right, so very quickly. So these trajectory groups were very strongly predictive of survival. And this idea of early identification, we think, held important clinical implications for things like medical decision-making, bed space, all these things, right? So what we're interested in is, rather than physiological data, can we do the same exercise with behavioral data from high-risk youth? And we think that there's similar implications, particularly for prevention. So, the idea of early intervention is important because universal prevention programs, we know that they might work, but they're very costly. So if we could target individuals earlier on for selective prevention programs, for those who are elevated risk, from a cost-benefit perspective, we might have a better bang for your buck and also reduce cost. The problem, though, this requires us to identify children who are at the greatest risk early. So in other words, can we identify risk factors for problem behavior for things like early substance use? And can we correctly classify those individuals from an early stage who are display the risk of behavior? So how do we do this? Well, there's two approaches. One is to use a static predictor. So if an individual has some risk factor or constellation of risk factors at time t early on, they have some percent chance or some likelihood of indicating risk. These individuals might be targeted for prevention programming. A second alternative is to use a trajectory of behavior as a predictor. So in other words, if we continually follow an individual as opposed to a static measure, is there a more precise way that we can note that they're at risk for the behavior of interest? So the first way we might think is related to something called the risk factor prevention paradigm in criminology. All right. The idea here is to identify key risk factors for things like offending or other outcomes and implement prevention efforts designed to counteract them. All right. The problem is that this is likely an inefficient way to do this. Could be, measures could be affected by temporary fluctuations in somebody's life. They could reflect certain circumstances as opposed to some steadfast problem of behavior which indicates risk. So the consequence here is that prognostic ability is very, very weak and limited in some sense. Alternatively, there's been studies which have looked at trajectories to predict outcomes. So trajectories of childhood behavior that in turn predict things in adolescence. So Bobby Brame and Dan Nagin and Richard Tremblay have looked at childhood aggression to predict things like delinquency in adolescence. Aggression trajectories predict things which is kind of robust across data sets and sites. And then also, if we're interested in predicting substance use disorders, aggression and delinquency trajectories also are linked to these things in adolescence. So what these results suggest to us is that longer patterns of behavior, as opposed to static measures measured at one point in time, may increase predictive validity in early adult outcomes. This leads us to an inherent problem, though, from a prevention standpoint. So knowing somebody's trajectory relies on observing them for a long enough period of time to actually be able to estimate a trajectory or for these patterns to emerge, which is completely incongruent with the idea of early intervention, where we want to target somebody as early as possible to get the best prevention outcome, but also cost benefit. So the point here, the question should we trade more precise prediction for earlier intervention. These two things seem to be at odds, which is what we're going to study today. So a question is, how early should these prevention programs be implemented if these behavioral patterns take time to manifest? Okay. So our research question here, we're going to be looking at specifically childhood internalizing and externalizing problems. And we're going to see how well they predict problems in adolescence, particularly onset of marijuana use and other substance use. We're going to hypothesize that these are predictive, and we're not the first people to do that. But then what we're going to study is how early we can classify individuals into their ultimate behavioral trajectory using data only observed earlier in childhood, and test this relative to longer patterns of behavior. We're going to use an analytic approach. This recent paper, which was published by Dan Nagin and colleagues, they call this approach Prob updates. I'll explain with more in a minute how it's done. But basically, it's going to allow for classification on your trajectory using just earlier waves of data as opposed to your entire longitudinal string of outcomes. So what we're going to do is we're going to estimate these trajectories of internalizing and externalizing problems over ages 6 to 13. Then we're going to consider the classification ability and the highest risk from earlier ages, and we're going to compare this length of prediction across time. So the data we're going to use here is from the Rochester intergenerational study. This is the Rochester Youth Development Study, which was the parent study of this. This was a large longitudinal study out of Albany, Rochester, New York, ran out of Albany, New York. It started in the 1980s. Then at the turn of the century, the oldest biological child of the participant was enrolled in this intergenerational study. Okay, so we're going to use 334 of these kids, and almost all the mothers report on their child behavior between 6 and 13. It's mainly minority, but half and half male and female. So the first thing we did was we estimated trajectories of anxiety or depression. You can think of this as kind of internalizing problems, and what we found was a solution where we had 3 trajectories. In particular, the red trajectory here would be the trajectory which is at the highest risk, and it's kind of a constant, steady risk over time. You notice that these trajectories don't overlap, okay? They're very well defined in the data, and I'll show you some justification for that in a minute. The other thing I want to point out is that if you look at these predicting things like early onset of substance use or incidence use in adolescents, this red group, this high group, is at the very elevated risk for that. They're much higher on average than all the others. These are the trajectories of aggression, aggressive behavior. Again, there's 3 groups. These are declining over time, is again consistent with other work on development of aggression over this period. And this high group, again, is at the same thing. The trajectories don't overlap, but there's a pronounced high group, which is also at an elevated risk for things like early onset of substance use. So these are some model diagnostics that are recommended to test whether this is a judicious model. And in both cases, I won't go too far into this, these are very well calibrated models. Okay, I want to use that point from what I'm about to show you. In particular, I want to show you this number, the posterior probability of group classification. What this is given your data, how well do we think you were produced by a certain trajectory group? All right, and it's very close to 1. Okay, this is indicating a very judicious model by any metric. Okay, so this is the formula that I used to calculate that, and all this is a Bayes rule calculation. In other words, the probability you were generated by a group given your data measurements. All right, and in particular, I want to emphasize that this is all of your data measurements through age 13. Okay, so given all of your longitudinal measurements, how well can we classify you in a group? The answer to that question is very well. But what if we did this same calculation, but we only measured you up through a certain age, 6, 7, 8, 9. So in other words, your longitudinal string of measurements, but only through a restricted age, and redid the same Bayes rule calculation. So now, given your longitudinal measurements only through age t, how well can we classify you into your ultimate group? So we did that, and based on the classification rule where the highest probability that you got, we classified you as that group. And then we did essentially a classification matrix where we looked at whether, since we knew what you actually were through age 13 versus what we could classify you through at any age, all right? So we did this, and you know, the people who are high and classified high, we would consider them true positives. And then people who are actual high but classified as not high at an earlier age, we would think of these as false negatives. In other words, these are people who would not be given programming, even though it would likely they'd benefit from it. And then we could calculate the false positive rate, or the proportion of people who would receive it, but actually wouldn't need it, since we'd misclassify them at an elevated risk. These are people that are actually low or moderate, but at an earlier age we'd think of as high. Okay, and then we looked at these rates by age. So this is for the anxiety trajectories, and you see that the sensitivity of the test at age 6, 7, and 8 is actually quite low. All right, so earlier on we have very low sensitivity. The true negative rate, the specificity rate, is pretty good. Right, that's pretty high throughout. But we have a low false positive rate, but a higher false negative rate. In other words, we're missing a lot of people we think are the case. Only once you get up through ages 9 and 10 do you start to see these numbers become much better. Same thing with aggression. We see the same pattern emerge with aggression. So the sensitivity of the test is very low at ages 6 and 7. It gets better through age 8 and 9. But the false negative rate at these early ages is very high, which we take a sign as for a 6 and 7-year-old, we have very difficulty classifying what their ultimate trajectory is. So to summarize what we found here, we have these elevated levels of internalizing or externalizing problems in childhood. They are predictive of things like frequency of substance use, delinquency, other problems in early adolescence. So we think that these are informative as risk factors for these problems, which is important. But consistently higher levels displayed over time are what we think implicate appropriateness for targeted prevention programming, not just the occurrence of one at a certain age. This is based on a considerable amount of misclassification, right? So these limited age spans through only earlier ages fail to correctly implicate these kids who might be at risk for these adolescent problem behaviors and substance use. So what are the implications? Well, if these prevention programs use just early age spans of data, like from teacher or parent, these might fail to provide programming to a key subset of kids who would likely benefit from these prevention efforts, which is indicated by our false negative rate. So we're advocating larger spans of information should be used to increase correct classification into these groups. Otherwise, it might be more beneficial to think of this at earlier ages for universal targeting. But I want to make the note that false negatives, they can be costly too. These are kids that we're going to miss, and going on if they engage in adolescent substance use, and this is going to incur massive societal costs. This is a number from NIDA, which indicates that 740 billion. We can debate the credibility of that number, but it's a huge number about things like services treatment related to adult substance use. So if we have longer age spans, which can limit the number of false negatives, this might be helpful in such a benefit cost application. Finally, some implications for criminological theory. It's not clear how we would reconcile this work with other work suggesting that individual assessments in kindergarten might be used with prevention efforts. So what we would argue is that these prior assessments were based on mainly stable personality traits. It's more difficult for practitioners to identify these types of things without more precise measurement tools. But things that are easier for these, like school counselors, nurses, teachers, to identify and monitor over time, like our behavioral measures, we think are easier to pick up. And again, we think that there's a lot of implications for life course criminology in terms of what this means for early risk factors and the precision of such efforts. That's all. Thank you.
Oh, okay. Success. All right. So you've heard some very interesting papers about substance abuse and at-risk youth, and now for something entirely different. I'm going to talk to you about street lighting. and present what I'm pretty sure is the first randomized control trial of street lighting. This is something we conducted in New York City. I'd like to acknowledge generous support from the Arnold Foundation for this work, as well as my co-authors, Ben Hansen, who's an economist at the University of Oregon, and Jason Lerner and Lucy Parker, who are both researchers at the University of Chicago Crime Lab. So when you think about controlling crime, right, I mean, I'm going to really simplify it here, but I think it's not inaccurate to say that there's sort of three sort of broad buckets of policy solutions you can think about. You know, one is obviously police and prisons, and I think there's plenty of evidence that these have some effectiveness, although probably far less cost-effective than we'd like, and a lot of collateral consequences of using these policy tools. And so we might search for another solution. Maybe we're thinking about social programs. And a lot of wonderful social programs out there, but it's really, really hard to get the right people into the right programs, and it's really, really difficult in particular to scale social programs and figure out how do you take some small program that works really well in one city and expand that to the entire country or the entire world. And so what I wanted to talk a little bit about today is the physical environment and whether we can make something that's a seemingly small change to the physical environment and maybe observe that has outsized effects on behavior. In particular, we might think that offenders, or maybe victims also, are maybe a little bit myopic and thinking a lot about what's going on around them in the instant and maybe a little bit less about what might happen in the future. And so when you think about streetlights, right, this is certainly not new technology. I'm from Penn, so I'd be remiss if I didn't tell you that Ben Franklin invented the streetlight in 1757. So here we are many, many years later. And why am I going to talk to you about streetlights today? Because actually, despite the fact that there's been quite a lot written on this, there's been no randomized evidence to date. So there's been a lot of pre-post studies. There's a city that had no lighting in an area, puts lighting in. Did crime go up or down? There's some with sort of ad hoc chosen control groups that maybe are reasonable or maybe not. And a lot of this literature is also very old. It's from the 1970s. A great deal of it concerns lighting up parking lots and garages. It's really about auto theft. It's not really about controlling street crime. And so this is going to be our attempt to see what happens when a city makes a targeted investment in street lighting to control street crime. And a couple of anecdotes that I found interesting. I'm a lifelong New Yorker, so this maybe it's very interesting to me. I hope it'll be interesting to you as well. So when you poll people in the communities that these lights are going to be put in, these are public housing communities, and I'll tell you a little bit more about what that entails shortly. But half of these folks say they feel safe walking around their communities during the daytime, but only 1 in 5 say they feel safe at night. And that's the first hint that at least people feel less safe when there's less lighting. And then this is one that really resonated with me in particular. So there's about 15 million complaints to the city's 311 system over a 7-year period. So this is where you complain about things like abandoned vehicles or vermin. And about 5% of these complaints are related to streetlight conditions. So New Yorkers really like to complain. 15 million of these complaints, 5% are about streetlights. That might not seem like a lot, but when you consider that there's 300 different types of complaints, the 4th most common complaint is about street lighting, in fact, even higher than rats, which is something else New York has a lot of. So, it really, I think, says something that people are paying attention to lighting. So the game plan here, first RCTU street lighting, I hope you find that cool. But this is going to be a very, very small randomized experiment. We're actually only going to intervene in 39 places. And that's really challenging as an analyst, right? I have a very, very small data set, and I'll talk to you about a little bit about some of the challenges and how we dealt with them. I'll cover that very quickly. If people have questions later, we can answer them. But what that really is going to mean is we can't just run a t-test, right? I'd love to be able to run a t-test. It's simple, no distributional assumptions. I'm not going to be able to do that because, again, we have a very small sample. And what that's going to mean is that I'm going to need to control for potentially confounding variables, both because randomization is potentially going to be imperfect in a very small sample, and I also need control variables to reduce residual variance to get the standard errors potentially a little bit smaller if I can. And so what that means is I'm going to have to make choices. And I hate making choices as a researcher because every choice I make, you know, maybe I make the wrong choice or maybe I'm influencing the outcome in some way. And so what we're going to want to do is to find a way to automate away our discretion and tie our hands behind our backs a little bit and hopefully convince you that we're presenting these results in a really honest way and that if we did this a little bit differently, we wouldn't get a substantively different result. And we're going to appeal to a couple different things. The main way we're going to handle this is to use something called the lasso or lasso regression. This is a tool that comes from statistics and computer science. It wasn't something that I was trained in grad school, but I've picked it up a little bit in working with some computer scientists. Briefly, the way this works is it's actually going to be very familiar, I think, to those of you who haven't seen it, because this is just least squares, right? I'm finding an alpha and a beta hat that minimize sum of squared errors. What we're going to just add is a constraint. And we're going to say that the parameter vector, the sum of the absolute value of the betas from regression, have to be less than some tuning parameter. And what that's going to do is it's going to retain some predictors, and it's going to get rid of others. And we're basically just going to use the covariates that actually predict our outcomes, which is going to be crime, out of sample, and we're going to get rid of everything that doesn't predict outcomes. And so I don't have to say, well, should I control for population or should I control for the log of population? I'll just sort of like let the model pick for me. We'll do some other stuff as well. That's going to be the central way we do this. I'll also talk about what the results are going to mean for public policy. So let me tell you a little bit about the field experiment here. So the setting is public housing in New York City. For those of you who are unfamiliar, New York is a very, very safe city by US standards. It would be a very, very unsafe city by Swedish standards. But where crime is in New York City, it's largely clustered in these public housing communities. And in New York, public housing is very big. So there's about 340 public housing developments. Some are single buildings, some are campuses of buildings, sort of like a cluster of really large dorm rooms. And about 400,000 people in New York live in public housing officially. Unofficially, it's probably like 50% more than that. So this is a very, very large population in New York. The other thing worth saying is that there's already lighting there. It's not like these places are pitch black. What we're going to do is add additional lighting to what's already there, and we're going to add lights that are going to be very, very bright. I'll talk about exactly what we're adding in a second. Just to give you a sense for what this looks like, this is a fairly typical development bird's eye view. You have some buildings, you have green space, parks below. This is sort of what this looks like from street level. There's a bench. You can see there's a light on the side of the building. They're generally not that bright. There's sometimes little playgrounds. And this is what we're going to put in, or have been put in. So if you've ever driven by the side of a highway late at night and you see some guys doing road work, that's what these are. They're really, really bright temporary street lights. They're a little bit noisy. If you get up really close, they don't smell so great. And so what I want to communicate is that this is the effect of lighting, but there also might be this demonstration effect, right? Everyone's really aware of what these things are. They're aware of why they're there. And so in thinking about how to interpret these results, I think the way I see this is sort of proof of concept for what can be done if a city wanted to sort of flood an area with streetlights in anticipation of future crime. But in thinking about what a lighting intervention would look like at scale, I think there's still some questions to be answered. So 80 of these 340 housing developments in New York City are chosen by law enforcement. It's the NYPD on the basis of crime and perceived need for more lighting. This is something that takes place over a 6-month period in 2016. 39 of these sites are randomly selected to receive additional light towers. Now, the city wanted to know how many light towers would be required to sort of observe a treatment effect. And so what we did is we took the 400 of these light towers, right? These are these temporary light towers, and we randomly assigned a different number to each of the sites that received the lighting. So some of these sites received a very small dosage of new lights. Other sites received a very large dosage of new lights. So we have a treatment control comparison that I'll tell you right now is a little bit underpowered. But we also, within the treatment group, have a comparison that's based on a differential random assignment of a dosage, an amount of additional lighting. And that's what I'll present to you today. So in the interest of time, let me just talk a little bit about outcomes, findings, and finally some public policy. So our main outcome here is going to be crimes that occur outdoors and at night, presumably the crimes that are most impacted by lighting. We're going to talk about index crimes, which we think are better measured, have better timestamps. You might be interested in whether there's spatial spillovers, right? You put lights on campus, does crime shift off a couple blocks away? I'm going to be underpowered to answer that question directly, but what I can say is if I take a very, very conservative stance on how to measure the effect of the intervention inclusive of spillovers, the effects are still going to be there. So whatever spillovers exist, they're small enough that there's still appreciable effects of the intervention on crime. So how about temporal spillovers? Well, we can look at daytime crimes that occur on campus. Now, it's a little bit funny, how do you think about temporal spillovers here? Some people have written that maybe if you show people that their community is cared for, that maybe crime could go down during the day as well. That's possible. But another thing that could be going on is just bad timestamps in some of the data. So if I wake up and my bike is stolen, and I call the police and say, hey, someone stole my bike, it's not clear what time the police officer is going to write down when that crime occurred. He might write down the report time. And so what we think is going to happen is some of the crime that happens during the nighttime, we're going to observe it in the daytime, and some of this is just going to be some mismeasurement. So take those estimates with a grain of salt. And then we're going to have a really key placebo test. I'm going to bring back the fact that we have a control group here. In fact, we did paired random sampling, and I'm going to re-estimate the results for the control group that has a random assignment of lights, but never actually received them, and I'm going to find no effect in the control group, which is good, right? I certainly shouldn't find an effect in the control group. This is just a visual. This is raw data. This is not conditional on anything. The y-axis here is the natural log of crime. The x-axis is the natural log of dosage, the number of lights per square foot, per 125,000 square feet. And you can see that the places that got more lights have less crime. That's if you look at the on-campus estimates here. If you look off-campus, these are adjacent areas where spillovers presumably could happen. The slope is a little bit positive. That's nowhere near statistically significant. And then what we're going to do is we're going to be really conservative and say, what if the treatment area is the campus itself, which got lighting, plus 2 blocks in either direction? We'll draw a circle around the campus, and we'll count all of that area as being treated, even though it wasn't. We'll fold in all the spillovers, and there we're still seeing a negative slope. So how do we actually estimate this in practice? We're going to run a Poisson regression. The covariates X are going to be selected using the lasso, and we're just going to see whether dosage predicts crime. And I'll run through this fairly quickly given time limitations, but we're going to find that on campus there's about a 60% reduction in outdoor on-campus crimes, outdoor nighttime index crimes. We're not going to see much evidence of spillovers to adjacent areas, but the standard errors are big, so I don't want to make a claim that there are no spillovers, just that we can't detect them. If we are very conservative about counting spillovers in these adjacent areas, I still see evidence that crimes, outdoor nighttime index crimes, go down by about 36%. There is some evidence of daytime crime reduction. This could be part of the demonstration effect of the intervention. It also could be just bad timestamps in some of the crime data. So it's a little bit hard to tell. But if you look at the control group, our placebo check, and by the way, we do a battery of checks to see if randomization works, and it does, and we actually control the randomization. But we also pass this placebo test fairly well. We do some robustness checks. We drop one development at a time because we only have 39 of them. It doesn't affect the results. We exclude the highest dosage developments. It doesn't affect the results. We also rerun these models many, many times using 10,000 different permutations of covariates. And you can get different results. I can find like a 75% reduction in crime or a 40% reduction in crime. I'm always finding large reductions in crime, right? It depends on what model you like, but we really can't kill the results substantively. So in terms of public policy, and I think I probably have like 20 seconds, I'll just say this. I think this is powerful proof of concept that crime can be very, very responsive to a small change in the environment. The longer effects are unclear, right? There could be some seasonality. This could be less efficacious over time. And the final thing I want to point out is that when you think about crime in public housing, only about 12% of it is outdoor nighttime crime. In fact, the most common crime in public housing, and since this is the criminology conference, I bet you're all guessing along with me, it's domestic violence. So when you think about street lighting, this is maybe affecting crime in these communities by about 4 or 5%, not 36%. So this isn't a panacea. It's very likely cost-effective if you believe the estimates in the literature. But there's still a lot of crime in public housing in New York City. And I'll take questions later. Thank you very much.
Excellent. We'll take questions. Ben, go ahead.
Yeah, this is for the, thanks. This is for the project about risk prediction for at-risk youth. So I was curious what, and it's always a little bit hard to look closely at tables and presentations, so I totally may have misinterpreted it. But one thing that I was picking up when I was looking at the tables was it looked like you guys were really good at predicting at very early ages who was going to be high risk. When you predicted that someone was going to be high risk at an early age, you were really good at doing that. But you weren't so good at capturing all the people that actually were ultimately going to be high risk. Was that right?
That's correct, right.
So I was curious how, you only had a minute to talk about implications, but I was curious how you think about that pattern for implications for risk prediction. Because I would think that maybe the answer is we should start doing risk prediction really early, but recognize that we have to keep on updating our risk prediction as these kids age out.
Right, so I think that that's correct. And the other thing I think is that these models of prediction need to be dynamic, right? So I mean, the idea of incorporating things that are traditional risk factors that are static, they can also evolve over time, by the way, in accordance with data which is updated continuously. And we can sharpen our predictions basically at every age to get a better prediction. But otherwise, we're not going to be able to pick up those kids, which doesn't mean we shouldn't be trying, making the model sharper. That doesn't answer your question?
I'll warm up. I'll have a follow-up to that. So have you guys looked at to what extent it has to do with the proportion of the data versus the age-graded nature of it? So, is it just that, part of it is, the more data you have, the better you should be at the prediction, right? So, by age 9, you're doing great because now you have, a good proportion of the data. But there's also a lot of work that suggests that there are important shifts happening at each of these ages, and to what extent does the actual age at which you're starting the prediction matter, right?
Oh, that's a good question. You mean if we, for instance, if we started earlier, even earlier or later, for example,
right,
does
so
it matter?
If you took the same proportion of the data and used that proportion of the data at different chunks, right? Because there's a conflation in what you're doing, which is you're capturing later ages, but also you're getting more data,
Right, that's right.
So like if you had the same amount of data at different chunks of the distribution, do you do that?
Right, so we were constrained with the data. We couldn't go any earlier. We started as early as we could. But I mean, it's quite likely that if we did it earlier, we had more data, that maybe age 6 would have looked different if we would have observed people before. That can't rule that out. But when you do this exercise later, the same pattern emerges as we find it. So in other words, the conclusion is you need more data to calibrate the model. Whether that's independent of age or not, I can't say, but you certainly, you know, the number of observations are what makes it sharper.
Thank you. This is about the street lighting project. Aaron, did you perhaps think about cross-validating your results on sort of pseudo-experimental model where you use data about random blackouts?
Yeah, interesting. So in another project that I'm working on now, we have data on streetlight outages, not blackouts. Blackouts are a little funny because human activity changes a lot, right? It's sort of a little bit unnatural. But we know when streetlights go out in the 3 largest cities in the US, New York, Chicago, and LA. And so we got like data on 2 million outages, and we're starting to put that data together. And so I think that will also be informative. I think a little bit more informative with respect to what a native street lighting intervention might look like. I'll let you know when I have results.
Okay, thank you.
One more question about street lighting. I'm wondering whether it's really about lighting itself, or it's about the effect of the strange, big, new objects that, you know, emits a lot of light and it's basically maybe it's effect of observer. So that's my question.
Yeah, no, I think the honest way to present this is to say, like, look, there's this intervention that does several things. It really increases the amount of lighting, but it also puts this big, very obvious object in the middle of these communities that everyone knows why it's there, right? I walked around these communities, I talked to people, like, they know why the lights are there, they know it's about crime. And, you know, some people have even said, well, does this mean we're being watched? Are there, like, cameras up there? So it could be other things, right? I think what I would say is, like, this is, with respect to external validity, I feel pretty comfortable saying, you know, I think this speaks to the idea that a city's worried about an oncoming crime wave, and it says, well, let's put a bunch of really big, obvious lights in a place. I think this might speak to that. You know, with respect to, you know, engaging in like a $1 billion infrastructure project to upgrade lighting, I think we should be a little bit more careful about what these results mean. I think more research is needed, right? It's sort of a great answer in a conference of researchers. We need more research. But you know, I think I just want to make sure that I'm not overselling what we can say from this. Yeah.
Sorry, just to follow up on that, did you think about maybe putting those lights in certain locations but not turning them on?
Yeah, so I wanted to do that. The city didn't want me to do that. So yeah, that would have been really nice. The other thing that I really wanted to be able to do is see exactly where crimes occurred on campus, like did they occur under the lights or elsewhere. But the way NYPD data is geocoded, you can't get that granular. But that would have been very interesting. Part of what I'm hoping for is that we've had a little bit of publicity from the paper. I'd love for someone from another city to get in touch and say, hey, we're thinking of rolling out streetlights, and that would be like one of my biggest suggestions for a follow-up study. Yeah. Yeah.
Thank you all for very interesting presentations. I have a question, or actually two, for the social network. One is that you mentioned that people who were joining peer support groups were able to retain much of their social ties. Did I understand you correctly that it was the social ties that they had when they were sort of engaging in treatment? And the second one is, did you, in your cohort, have people who identified themselves as in recovery? And did you see a difference between these in the social ties?
So for the first question, both the people who joined peer support groups started with larger networks and experienced less of a slope of decline. And for the second question, there are people that identified in recovery. The majority of the sample participants had been in recovery at some point, and many of them had been in and out of recovery at different points. And we have done some tests to look at whether recovery differences are there, but they're not enormous. I think one of the things that kind of emerged from a lot of our stuff is some of the fluidity of these use patterns for a lot of people. Many of the people who self-reported being in recovery on the survey module then talked about how they were only using once a week or only using in kind of periods of crisis. So I think, as a person who's not a original substance abuse researcher, several of my colleagues are real substance abuse kind of people. A lot of these patterns really surprised me. I tended to think of some of the more bright lines, like being in recovery versus not, but really a lot of the patterns were very kind of fluid between people and what the states they're in.
Aaron, I was wondering what people's reactions were to the lights. Were there a lot of complaints? Like, what's the experience like? I would think that, yeah, there are crime reductions, but there are probably some important social costs too. What happens to the street? Do people spend less time on it? Can you tell us anything about that?
Yeah, so one of the things that we really wanted to do but weren't able to do is use some technology to count, like to see if more people were outside during that time. We weren't able to do it. I can speak a little bit to what public reaction was. So. So the city surveyed people in these communities about the lights, and if you believe the survey, like 97% of people in these communities love the lights. But then if you look at who responded to the surveys, right, they're like all women over the age of 50. And I think out of 2,000 survey responses, less than 20, fewer than 20 were young men. So take that with a little bit of a grain of salt. But look, the people who are politically powerful in these communities, who have influence with the mayor's office, fought very hard to keep these lights. In fact, this was a 6-month pilot, but some of the lights actually remained because people in these communities have fought to keep them. Now, when I was out there actually talking to some of the young men who were hanging out outside, sentiment was a little bit different, and I won't repeat verbatim what people told me, but I think people felt like they were being surveilled and these communities were really safe. And as one guy put it, he's like, man, if you get shot here, like, you deserve it, like, because this is a pretty safe community. You're probably doing something you shouldn't be doing. It's a little bit hard to know how everyone feels about the lighting. There were some complaints made from some people who were worried about health impacts of lighting. So there are standards for how many lumens of light you're supposed to be exposed to, and if you're standing like directly under these lights, there's a massive number of lumens, like 600,000 lumens. But like for people who are like sleeping in their 4th floor window and a little bit of light comes in, it's far less. I think it's for any city that's considering doing this, and scaling this, I think that should be thought about. But it was really only raised by a couple of people who were sort of lights activists. By and large, the reaction among the people who respond to surveys was very positive.
I feel like I may need to cold call. Sean, you must have a question.
In some ways, I'm having a really hard time thinking about your classification. I mean, if your alternative is universal treatment, and you have a system that misses a bunch of people but does a pretty good job of capturing a fairly high proportion of the folks that are going to be at risk, I mean, it's a very different trade-off. And if you only have a limited number of resources, that's actually a good trade-off. Like, I mean, in other words, you're not getting a lot of false positives, you're getting false negatives, you're not going to capture everyone, but if the goal is to target your resources and you have limited number of resources for which you can actually do the treatment program, what you're showing both in the static and dynamic model is that you can do really well really early of capturing at least a certain proportion of the positive group. So I'm not sure why the message is bad classification. If the goal is to do targeted policy, you have a really good targeted policy. You're just not going to capture everyone. So I mean, I guess I had a different interpretation from your slides that was similar to what Ben was saying, and I was sort of unsatisfied with your answer. But I was going to talk to you later before Sarah. So it's really Sarah's fault that I'm putting you on the spot here.
Okay, I figured it was coming.
Afterwards.
I mean, but so the point is we're good at predicting the model that we show, that we're good at predicting who the people we classify as high risk or we're generally good at, right? But I mean, if for a targeted intervention, you're saying, well, you're targeting people that should be hit. I agree with that. But you're also missing people that shouldn't be hit. So the alternative is to do universal prevention, and you're going to be more likely to hit people that, you know, depending on how large that false negative rate was pretty large, right? So, I mean, you're missing people by, even though you're hitting the people you think you want to get, you're still missing a lot of people. So I'm not clear why the alternative of being universal is not as good as that.
So you have two very big trade-offs, right? I mean, in the universal program, you're going to capture a lot of people that don't need it. And in some cases, that may be harmful. And in your case, even in the early ages, you're only going to capture the people that need it, and you're going to miss some of the people that could have used it. It's a very, I mean, that's a very big difference in terms of policy. And from a point of view, if you have limited resources to expend much more intensive programming on it, that's not a bad trade-off. And so, yeah, you're going to miss some people, but you're not going to be delivering services to people that don't need it. And you may not be, you know, for example, doing harm, because there are some studies that show some of these prevention techniques do harm to people that if you deliver it to those that don't need it. So, I mean, to me, it's not clear to me necessarily which is the right answer, but what you've done is present two very realistic, different choices that the way you presented your results isn't very clear. But to me, the choices are actually much clearer.
Just to respond to that, I mean, what we didn't present here is omitted from this, or what the you know, in terms of the actual benefit cost, right? So, if the, you know, we think that the cost of a false negative is potentially pretty high, right? We haven't actually done that and calculated that, but if it is, then that argues that those people should be being hit with these prevention programming processes. So I would say that in absence of knowing what the cost of it is, you really can't make the trade-off that you're arguing. I mean, they seem like two very different things to me. You're either missing a lot of people, right, which could have implications down the road for cost, or your cost is up front and might not be as effective.
There's a question up front.
I just wanted to ask the discussion that one thing to target the right kids and missing some and adding some that don't need any help, but also how efficient are those interventions? What do you know about we don't talk
how
about
effective are the interventions, you mean?
Yes, because they're not that very efficient, and they could also be stigmatizing for those kids. So I suppose that's one part of the equation that one has to bring into the picture.
I completely agree, and you can imagine like the intervention, if you're thinking of this exercise from like a formal justice intervention, if these kids are older, it could have very severe implications of making a mistake, right? Our results indicate that we don't make those types of mistakes. We make the opposite kind, where we miss out on the intervention. But from what we know, targeted intervention is generally more effective than global or universal interventions at these earlier ages. But the type of intervention implicates very different costs when you're talking about false positives and false negatives, right?
Well, if there are no more questions, I think we can just thank the panelists one more time.